Hi, we'll continue with the patient assessment. This is the second part of this series of lectures. The last part we have just discussed within the last lecture was the extraoral examination of the temporomandibular joint. Today we'll continue with the extraoral examination, including the examination of the lymph nodes and the thyroid gland. For the examination of the lymph nodes, the anatomical distribution of the lymph nodes that is in the head and maxillofacial region include the submental lymph node, submandibular lymph nodes, periauricular, postauricular, occipital. We also have the cervical chain of the lymph nodes, which is divided by the sternocleidomastoid muscle into superficial and deep cervical lymph nodes. We also have the supraclavicular and the intraclavicular lymph nodes in relation to the clavicle. These are the major lymph nodes that is situated within the head and neck region. The most important lymph nodes that receive drainage from the oral cavity is the submental and the submandibular lymph nodes. In order to examine the lymph nodes, the operator needs to be systematic. So you need to follow a sequence just in order to avoid missing any lymph node. The most common sequence, as we have just said, is the submental, submandibular, periauricular, postauricular, and then you move further toward the occipital and then down to the cervical chains of the lymph node. You need to use your both hands when you examine to allow comparison between the two sides, and you can either stand in front of the patient or behind the patient. Being in front of the patient will give you the chance to inspect the patient's expression during the examination. So if there is any tenderness or pain, the patient would give like expression with their face, and you can be easily recognized by the operator. Having been stand behind the patient will give you better control over the patients during the examination. The patients need to sit in an upright position and with their head slightly tilted forward. This would allow the neck area to be relaxed, which allow the examination. Once the patient stretch their neck, the platysma muscle will make the examination difficult. There are 5 characteristics we need to observe during the examination of the lymph nodes. This would include the location, size, presence of pain or tenderness, the degree of fixation, and the texture. The location, for example, we can say a right or left, submandibular, submental, or whatsoever lymph node, and then we record the size of it. The lymph nodes can be preserved as it is enlarged within the head and neck region if it is more than 10 millimeters in diameter, about 1 centimeter. If it is more than 1 centimeter, the operator can record it as an enlarged lymph node. The presence of pain or tenderness. If you have examined the lymph node and the patient feels pain, so you record within your files as enlarged and tender lymph node. For example, enlarged and tender left submandibular lymph node. And then you would observe the degree of fixation, whether the lymph node is being freely movable or fixed. Having a lymph node that is freely movable, enlarged and tender would give a hint about a lymph node that is enlarged due to inflammation, a lymph node due to, for example, a dental infection. Having a lymph node that is fixed to the deeper tissue, hard to palpation, that is usually not tender and enlarged, this is in most instances goes with a lymph node due to metastatic tumors. So it's very important to have these 5 characteristics recorded when you examine the lymph node. The texture, being soft or hard, is also important. Having a lymph node of soft due to inflammatory is different from the lymph node that is due to metastatic tumor, which is very hard during the examination. Moving from the examination of the lymph nodes, we goes to the examination of the thyroid glands, which is part of the extraoral examination. In order to examine the thyroid gland, we need to understand the anatomy of this area. If we started our finger from the chin of the patient and we slide it downward, as you see here in the picture, the first prominent structure you would hit with your finger would be the Adam's apple, which is part of the thyroid cartilage. Being named as the thyroid cartilage, it has no anatomical relation to the thyroid gland itself. If we move downward, we have a depression, which is the cricothyroid membrane. This is an important structure that can be used during tracheostomy. If we move down forward, okay, we have the cricoid cartilage. The cricoid cartilage is also prominent hard structure, not as prominent as the Adam's apple, but can be differentiated from the depression of the cricothyroid membrane. Moving down from the cricoid cartilage, we have the tracheal rings, the first and the second tracheal rings. The isthmus of the thyroid gland overlies those structures. If we slide our fingers slightly on the side, about from 1 to 2 centimeters apart, we have the loops of the thyroid gland. During the examination, the operator needs to stand behind the patient and use the pad of their fingers rather than the tips. And then, as we follow this anatomy, once we hit the isthmus of the gland, we ask the patient to swallow. Okay, the patients need to sit in an upright position, okay, and the neck is slightly, and the head of the patient, needs slightly bent forward. Okay, once we examine the isthmus, we move our fingers apart to examine the loops of the gland, and we also ask the patient to swallow, because the loops of the gland and the whole thyroid gland will move during the patient's swallowing cycle. If there is any enlargement, okay, we would record it in our notes. Sometimes we push from one side to examine the loop on the other side. This is all what we have for the thyroid gland. Moving from the extraoral examination, we move into the intraoral examination. For the intraoral examination, we examine from the outside and we move further inside into the oral cavity. Moving inside into the oral cavity from the outside, we start with the lips and then the lining of it, which is the labial mucosa, and then further inside, which is the lining of the cheeks, the buccal mucosa, and then we examine the buccal and lingual gingiva. Hard and soft palate, the tongue, of course, including its dorsal, ventral, and the lateral surfaces of it. The floor of the mouth needs also to be examined, and the last part we examine is the teeth, which is the hard dentition. So we start with the soft structure, and then we move to the teeth. We leave the teeth as the last part of the intraoral examination. Never take your mirror and start examining your dentition first. You need to examine the soft tissue before we move intraorally to examine the teeth. Soft tissue and then the hard tissue. So you need to be systematic in your examination. The first part we would examine is the lips and the labial mucosa. The intraoral examination, as any other physical examination, would include inspection. So we would use the eye first, and then palpation, so we use the hands then. Okay, so by starting with the inspection, we would inspect the health of the vermilion border and the lips. Sometimes we have something like this, which is a chronic ulceration that is, in most instances, might be asymptomatic for the patients, have been present for long period, this might be a squamous cell carcinoma, and the lower lip is the common site for squamous cell carcinoma. We would examine the vermilion borders. If there is any cracks, fissures within the lips, we should make notes about it. Okay, we also examine the area of the commissures. If we want to examine the labial mucosa, the operator can invert the lips and examine the lining of it, which is the labial mucosa. The labial mucosa, once have been palpated, would include the lower labial mucosa, would include numerous minor salivary glands, which can be easily identified during the examination. Okay, it is covered by non-keratinized epithelia, so this would reflect the vasculature beneath the mucosa, giving it a red or dark pink in color. Okay, sometimes trauma to the lower lips can give enlargement like this, which is which occurs due to damage to the minor salivary gland. This is a mucocele that occurs within the lining of the lower lip. The buccal mucosa, which is the lining of the cheek, we need to stretch it by a dental mirror, for example, and examine it. It's also covered by non-keratinized epithelia, so also the lining would reflect the underlying vasculature. The most important structure, which is normal structure, is the papilla of the parotid gland, okay, which is just situated just opposite to the first molar. Sometimes we have structure like this, which is in numerous white spots just next to the commissures of the lip. This is called Fordyce granules. Fordyce granules is an ectopic sebaceous gland that is developmental in origin. Sometimes we have like this line, white streaks along the occlusal plane. This is linea alba, and it's occurred due to chronic irritation from cheek biting. The gingiva, you need to assess the gingiva, including from, for example, the consistency of it, the color, the texture. Normally it is pink in color, having this numerous, like giving its numerous indentations, giving it like an orange peel in appearance. Okay, this is a normal gingiva. Sometimes when you have an inflammation, it's become edematous, and we lost what we call the stippling of the gingiva. This is numerous indentations. It's called the stippling. Once the patients have, for example, gingivitis, okay, we will lose this stippling. Anything we note on the gingiva need to be recorded in your notes. The gingiva need to be examined from the buccal side as well as from the lingual side. Sometimes we have like this dark pigmentation within the gingiva. It is melanin pigmentation. It's normal, especially in patients with dark skin tones. Nothing to worry about. There is also the gingival biotype. We have a thick gingival biotype, thin gingival biotype, which is sometimes important to be established. The hard and soft palate. Once we moved further within the intraoral cavity, we have the hard palate. The hard palate is a hard structure covered by thick keratinized epithelia. Having a thick keratinized epithelia will occlude the vision for the underlying vasculature, so it wouldn't be dark pink or red in color. It's most like pale pink in color, and it has numerous ridges on it. It's called the rugae, and it is mostly situated within the anterior part of the palate. We also have this prominent structure just situated behind the two central incisors. This is the incisive pad, okay, and sometimes we have something like this, which is a prominent bony structure within the midline. I think you have already know about it. It's called median palatine torus palatinus or median palatine tori. It is normal bony exostosis, but sometimes need to be removed to allow insertion of prosthesis. If we move from the hard palate further into the oral cavity, we have the soft palate, which is the movable part of the palate. It's covered by non-keratinized epithelia, so in contrast to the hard palate, it is dark red or dark pink in color, dark pink or red in color, in contrast to the pale pink color of the hard palate. The soft palate, in order to be examined properly, we need to depress the tongue and ask the patient to say ah. Okay, as you can see, the tongue is being depressed. All what we need to do is to ask the patient to say ah to allow the elevation or the movement of the soft palate. It is also an area for the collection of lymphoid tissue. So sometimes during inflammation and infection, it is enlarged and appear congested and red in color. Moving from the hard palate and soft palate further into the oral cavity, we have the tongue. Tongue is an important part of the oral cavity as it is a site for oral cancer, so it needs to be examined properly. The examination of the tongue would include inspection as well as palpation. So we ask the patient to protrude their tongue in an attempt to touch their chin. Once the patients have protruded their tongue, the operator can take a piece of gauze and wrap it around the tip of the tongue to allow the operator to control the movement and also to examine the area properly and palpate it. The tongue usually covered by numerous papilla, which is the filiform papilla, and interspread by this pink spot, which is the fungiform papilla. Sometimes the filiform papilla get hypertrophic, okay, and then secondary pigmented by food substance, giving rise to black hairy tongue. Sometimes we have this filiform papilla become atrophic and removed, and once the tongue is become depapillated, it's become red and smooth in color. This happens during, for example, nutritional deficiencies and anemia. Sometimes we have area of hyperplastic filiform papilla interspread with an atrophic area. This can happen in migratory glossitis or geographic tongue. Sometimes we have a thick white coat covering the tongue, for example, for patients with having fungal infection, candidiasis. And sometimes we have deep fissures, like for example, this is cracked tongues or grooves. Tongue examination should also include the examination of the lateral border. So once the operator have a grasp on the tongue, or sometimes we ask the patient to move the tongue on the side. Once you have moved the tongue on the side, you notice there are sometimes vertical grooves on the side of the tongue, which is a normal anatomical landmark for this region. Sometimes, in some instances, patients might report a long-lasting ulcer like this one, which might be a squamous cell carcinoma. The ventral surface of the tongue. In order to be examined, we ask the patient to elevate their tongue in an attempt to touch the anterior part of the palate. It has a numerous vasculature, and it is have this prominent structure, which is the lingual frenum. Lingual frenum attach the tongue to the floor of the mouth. Sometimes the patient have an abnormal attach of the lingual frenum, giving rise to this condition, which is ankyloglossia. The floor of the mouth also need to be examined. After the patient have elevated their tongue, we can have a look also on the floor of the mouth. The floor of the mouth can be examined by means of inspection and palpation. Palpation can be done by sandwich technique, using the fingers from the intra-oral region and an opposing finger to support an area just beneath the chin, and then we examine the structure in between. Normally, we would notice the lingual frenum, as we have just said it earlier, and on the side we have the papilla for the submandibular gland, and sometimes even the sublingual glands attached to it. Sometimes we have this white lesion that occurs within the floor of the mouth. It is called leukoplakia, and it needs to be examined from time to time because it can cause area for squamous cell carcinoma. Okay, this is all what we have for the examination, intraoral examination and the extraoral examination. If you have any questions, please leave them in the comments below. Thank you.